Well, good morning,
Okay.
everybody. Yesterday we were talking with Dama because I think that the best way to do this is just to
We're
give,
on. We're on, eh?
yeah. I think that the best way to do this is just to give the honor to the Dr. Eva, just to
Mm-hmm.
go for a short presentation about her work, and I think that maybe you can explain us in a short way how is the way for the patient with epilepsy go for genetic tests, and why is the reason to request a genetics test in a patient with epilepsy, so
Okay.
that way the
Okay. But
community with epilepsy can understand it, no?
okay. But give me a moment. I will give an introduction first, and then we can start. Okay. Bon dia, bon dia, bon dia, Turende. Good morning to everybody joining us via our Facebook page from Stichting Epilepsie Curaçao, na area Winkelaar, and also joining us via the YouTube channel. For the people in Europe, especially in Netherlands, it's already afternoon. Good afternoon. There in Netherlands, it's almost about 3 o'clock, Dr. Brilstra. Is that it's
That's
almost three
right.
o'clock there, no?
Mhm.
Okay. And today we have a very, very interesting session entitled Meet the Experts. Let's talk about epilepsy and genetics. As you know, this session will be conducted in English to enable us to reach a broader audience and share this important information with as many people as possible. But if you have a question and you don't know how to put it in English, send it in Papiamento and we will arrange it so you can get your answer to your question. My name is Bruna Quidama and I'm the founder and president of the Stichting Epilepsie Curaçao na area Winkelaar. And only as the Stichting, as the foundation, we could not accomplish alone this mission. Thus, we're very honored and grateful to Dr. Eva Brilstra. She is all from Netherlands here, joining us here in Curaçao today. She is a clinical geneticist, if I say it good,
Very
working
good.
at the University Medical Center Utrecht, the UMC Utrecht in Netherlands, where she works in the field of neurogenetics. Her clinical and research interests focus particularly on monogenic epilepsy syndromes. I hope I said it good. Dr.
Excellent.
Brilstra, thank you very much. We are honored to have you joining us today, as I said, and for sharing your knowledge, experience, and precious time for us today. Thank you. We also are honored with our second guest, not a person nobody knows. Everybody knows Dr. Daza, Anilu Daza. She is our neurologist and epileptologist here in Curaçao, working at the UMC. Daza is a highly respected and deeply appreciated by her patient here in Curaçao. And that is for the way how she work, how she approach care, very compassionate. And she is known not only for her expertise in epilepsy, but also for the time and dedication she invests in understanding each patient, unique situation, and challenges here in Curaçao. And last but not least, we have our board member, Yaskara Halabi, who is joining us also today. And she is going to moderate today's discussion, guiding the conversation, and helping us address questions for the audience. So, Yaskara, floor is yours. And I ask everybody if you have any question, send it to us and we will forward it so you can get the answer. Yaskara, the floor is yours.
Good morning, everybody. I I believe that Dr. Daza did have a brilliant idea just now. Why don't we listen to um, Dr. Eva Brilstra, her findings, what is the importance of genetics, what kind of impact would it have on the life of current persons with epilepsy, or is it more for the future? Do you agree, Dr.? May I call you all Dr. Eva and Dr. Anilu? That's like,
Yes, please, please.
okay. Do you think that's more convenient, Dr. Eva?
Yes, please. Yes, I prepared a presentation actually, so I might start my PowerPoint now, if that's okay with you.
Yes,
And
completely.
if it takes too long, or if it's too complicated information, or just interrupt me. And maybe if you think it's better to just answer questions or have a discussion, we can stop the presentation and proceed with that.
Okay.
Okay. So I will start to share my screen. Now, hold on a second. So, so can you see it now? I can put it in presentation mode. Can you see my presentation now? My first slide?
No, we don't see it.
Okay, that's strange.
I'm seeing the four of us.
Okay. Try again. Stream. Present, share screen, I think.
Yes, I think that is.
And then share screen again. What do you want to share? Share. And now?
No.
No, not yet.
No? Okay. Well, what I might do, because I don't know how to solve this problem.
Let me see if I can help.
I try it again. Slides and PDFs, perhaps. Your computer. Currently support. Okay. Hold on. I think maybe now, if I first. So. It's uploading.
Okay.
In the meantime, I can send it to you by email, perhaps, if I don't succeed. Maybe one of you can share.
Okay, no, yes, that's an option, yes, for sure. Oh, now
Oh, there it is.
Yeah.
Yes?
Yes.
Okay.
I had to add it to the stage after it loaded up.
Okay. Yes. Okay. Can everybody see it? Is it fine
Yes.
like this? Yes?
Yes,
Okay.
you can see it,
Okay.
yes.
Good. Well, I will tell you about epilepsy and genetics. Thank you very much for the invitation. I'm very honored, and thank you also for your kind words. I will start with a short biology lesson on DNA and DNA variants. Apologies for that, but I think that will make it easier to understand the next topics. Genetic causes of epilepsy. When should you consider DNA testing in an epilepsy patient? And what is the relevance of genetic diagnosis? Well, I think I can skip this slide. About DNA and genes. DNA is the genetic material that parents transmit to their children. And you can see it as a textbook, which is written in only 4 letters, called A, C, G, and T. And the complete human DNA contains about 3 billion letters. A gene is just a small section of DNA that contains the instructions for making a specific protein, which has a function in the body. And altogether, humans have about 20,000 genes. Genetic variants are differences in the DNA textbook, so in the DNA sequence. And if you compare 2 unrelated individuals, 99.9% of their DNA is identical, but at 0.1% of positions, there are differences, variants in the DNA. And we roughly can recognize 2 types of DNA variants. First of all, common variants, which are present in all people. And a specific common variant is present in more than 1% of the population. And these common variants have no, or if they are related to epilepsy, they only slightly contribute to epilepsy risk. I see that my text is a bit mixed up, but I hope you can still read it and understand. And then in addition, we have the rare variants, and these are present in mostly only few individuals, or even only in one individual. And if this rare variant is present in a very important part of the DNA, in a gene with a crucial function, it may cause a monogenic disease. And if it is in an epilepsy gene, a monogenic epilepsy. In this picture, you can see how knowledge on the etiology, on the cause of epilepsy has increased over the last decades. On the left was the situation in 1975. Then we knew especially acquired causes of epilepsy, like trauma or stroke or cancer or infectious diseases. But in most epilepsy patients, the cause was unknown, and we call that idiopathic. And on the right, you can see that by now, we know that in all these epilepsy patients without an acquired cause, genetic variants play a role in one way or the other. As I told you about common and rare variants, these are associated with polygenic versus monogenic causes of epilepsy. And what is meant by that? Polygenic means that the epilepsy is the result of the sum of a very large number of common variants, which each individually only slightly contribute to the risk. So each single common variant only gives a minor increase in the risk to develop epilepsy and will by itself not cause epilepsy. But if you have enough of those risk factors, you will develop epilepsy, as opposed to monogenic epilepsy. And in these cases, one single variant in the DNA is enough to cause epilepsy, because the variant is present in an important part of an epilepsy gene. And this is an example. Apologies again, the figures are all mixed up. But here you can see that this T in this position has been replaced by an A, and this disturbs the function of the gene where this sequence is part of, and then it causes epilepsy. So this is the field of clinical genetics, and this is what we are looking for. So monogenic hereditary types of epilepsy. In the majority of epilepsy patients, the cause is polygenic. So having a genetic monogenic hereditary epilepsy is rather rare. But when should you think of a monogenic hereditary epilepsy and consider DNA analysis? You should consider that in cases of familial epilepsy, especially if it occurs in the family according to a monogenic pattern of inheritance. And I will tell you a bit more about it in a minute. Also, if the epilepsy is drug resistant, and you are looking for a better way to treat the epilepsy, then a genetic diagnosis may add in making choices. And also in patients with epilepsies and with epilepsy and comorbidities, like developmental delay or intellectual disability, autism, movement disorders, and so on. And when we think about DNA testing, we can recognize 3 subtypes of epilepsy. First, generalized epilepsies, in which both hemispheres are affected very early in the seizure, as you can appreciate here. And examples of generalized epilepsies are well-known epilepsy syndromes like childhood absence epilepsy or juvenile myoclonic epilepsy. The second subtype is the focal epilepsy, in which seizures originate from a specific area or network in one part of the brain. And then the third and most important category from a clinical genetic point of view are the developmental and epileptic encephalopathies, DEE. And these concern young children who not only have seizures, but also developmental delay or intellectual disability. And in these syndromes, both the epileptic activity and the underlying genetic cause contribute to the developmental delay. Well, genetic testing in generalized epilepsy is in most patients not necessary, because in the vast majority of patients, the epilepsy is polygenic and does not have a monogenic cause. So in generalized epilepsies, there's no indications for DNA analysis unless the epilepsy is associated with comorbidities, like I mentioned before, or if the clinical picture is compatible with GLUT1 deficiency syndrome, which is a very rare monogenic condition in which the glucose, the fuel, is not properly transported from the blood into the brain. So the brain does not get enough fuel, and this leads to seizures, but usually also to a developmental and epileptic encephalopathy. In that case, you would consider DNA testing anyhow. But in atypical cases, it may present with a very early onset absence epilepsy. So these are children who are only 2 years old, for example, and they already get absence epilepsy. In general, if you consider generalized epilepsy, for example, a parent with a juvenile myoclonic epilepsy who wants to have children and wonders what is the risk for children to also develop epilepsy, that is on average 8%. Then focal epilepsy, that may also have polygenic etiology, but in addition, there may be a DNA variant which is somatic, and with that we mean that it is only present in a small proportion of brain cells, and from those brain cells the epilepsy originates. And you can understand that in case of a somatic variant, a parent will not transmit the genetic variant to his or her child because it's not in the ovaries or in the sperm cells. So in these instances, with a polygenic etiology or a somatic genetic variant, the recurrence risk for children is also low, even lower than for generalized epilepsy, on average 3 to 4%. But in 5 to 10% of patients with focal epilepsy, there is a monogenic cause. And in that case, the recurrence risk for children may be up to 50%. And we now know 22 genes for monogenic focal epilepsy. And the most important ones are presented here. These are 3 genes, DEPDC5, MPRL2, and MPRL3. And together they form the GATOR1 complex. And this GATOR1 complex inhibits a very important pathway in the body, also in the brain, the mTOR pathway, which has an important role in cell growth and differentiation. And GATOR1 related epilepsy, so focal epilepsy that is caused by a disease-causing variant in this GATOR1 genes, has an autosomal dominant pattern of inheritance, which is illustrated by this pedigree. This is a family. The squares are male and the circles are female, and these are parents and these are their children, and so on, the subsequent generations. And all individuals with this small square have epilepsy. And autosomal means that both females and males may develop epilepsy. And dominant means that for each child of an affected parent, there is a 50% chance of inheriting the DNA variant. And a specific characteristic of this Cato-1 epilepsy is that there's reduced penetrance. And that means that not everybody who has the DNA variant develops epilepsy. If you consider, can you see my arrow? Can you see it? If I show something, is it visible for you or not?
I think that I think so.
Yes, can you see it? Okay.
You see it? I don't see it.
No?
Wait. No. Maybe try to change the screen that you are sharing, you know?
Well, I'm afraid that then my presentation, I will lose my
for sure.
presentation.
Yeah.
So maybe I better
We'll
stay and then I'll just explain. I hope you can follow what I present up till now. Can you? Is it clear until now?
Yes.
Okay, thank you.
So far, I think, yeah.
Okay, so in this pedigree, you can see, for example, the parents in the third generation, or in the third generation on the left. The female does not have epilepsy, but two of her children do. So she must have the genetic abnormality, but she never got sick. So that is something that we see in Cato-1 epilepsy, that about half of the family members who have the disease-causing variant don't get epilepsy. But the family members who will develop epilepsy show a large variability in severity. So some relatives with epilepsy only have a few seizures that respond very well to anti-epileptic drugs, but others may develop a very severe and drug-resistant epilepsy from a young age onward, which is accompanied by developmental delay and often also behavioral difficulties like autism or hyperactivity. So this is a difficult situation when, as a parent, you have a mild epilepsy, but you know that when you transmit the genetic abnormality, it may turn out to be very severe in your child. But you don't know on beforehand. Well, then the third category, and this is what we see most often as clinical geneticists, the DEEs. These are young children with epilepsy and developmental delay. And by now we know hundreds of genes that may play a role in these conditions. And in most cases, the disease-causing DNA variant has arisen newly in the child. So every child has few new DNA abnormalities compared to the parents. That is the case in all of us. But in most individuals, they don't cause any harm. But if such a new DNA abnormality is present at an important place of the DNA in a gene with a crucial function, it may result in a severe monogenic epilepsy. And you can understand that in these cases, epilepsy often is not familial because the DNA abnormality has arisen newly in the child. And especially in the last 20 years, lots and lots of genes have been identified that may play a role in these DEEs. And we can identify a disease-causing variants in about 50% of these children, but we think that a monogenic cause must be present in many more. And a well-known example of a DEE is Dravet syndrome. I don't know if you know it, if you have heard of it or know patients with it perhaps. This is from the slide of the Dutch Patient Foundation. Some works of art that have been made by Dravet syndrome patients. just as the picture on my first slide. Dravet syndrome is a subtype of developmental epileptic encephalopathy with onset in the first year of life, with seizures provoked by fever or fractionation in previously completely healthy infants. So these children are develop normal and are completely healthy until they get their first seizures around the age of 6 months old. And then they get more febrile seizures, and in the second year of life, they start having afebrile seizures with different seizure types, generalized tonic-clonic or hemiclonic or myoclonias, and also have status epilepticus. And with seizures becoming more frequent, the development delays, usually in the second year of life. And when children are about 10 years of age, they all have an intellectual disability and often also behavioral problems and movement disorders. How is DNA testing performed? Patients get an appointment at our outpatient clinic. And of course, we collect all relevant information. We talk with the patients about their clinical history or with the parents, and collect information about the family. We draw a pedigree, as I presented earlier. And then a blood sample is taken, and the DNA is extracted from that. And we can do a lot of DNA tests with just one blood sample. And then we can opt for testing only known epilepsy genes, or even only the known genes for focal epilepsy. And this is what we do when the patient only has epilepsy. But if comorbidities are present, we prefer to test a large gene panel of genes with that are associated with intellectual disability. And most of these genes can also have epilepsy as a symptom. And you can see that this is really a large number of genes, over 1,700. And if no cause is identified, we may go on and sequence, investigate the whole DNA book. So then we look for every of the 3 billion letters if the right letter is in the right place. And when we do such extensive DNA testing, we also include the DNA of the parents, and we compare all the DNA variants in the child. This does the computer with the DNA of the parents, and only the variants that are present in the child but not in the parents are further analyzed to see if this is a plausible cause for the epilepsy. What is the relevance of a genetic diagnosis? Well, of course, the relevance is clinical. Sometimes a genetic diagnosis may lead to adjustment of treatment. For example, in Dravet syndrome, treatment with sodium channel blockers is contraindicated. That may cause, do harm, result in an increased seizure frequency. Sodium channel blockers like carbamazepine, which is a drug which is very often used. Or a treatment may be stopped, or even palliative care may be started if a prognosis is very poor. But the consequences are also personal. So we may do genetic counseling, inform parents about the recurrence risk. For example, if we indeed have found a DNA variant that caused the disease and has arisen newly in the child, parents don't have to worry about next children also being affected. The recurrence risk is then very small, only 1%. If there's a larger recurrence risk, for example, in the case of the Skater-1 epilepsy, parents may opt for reproductive choices like prenatal testing and pre-implantation genetic testing. I will tell you a bit more about it in a minute, but there are also important psychosocial consequences. Some parents have been looking for a diagnosis for years, so a genetic diagnosis ends the diagnostic odyssey. And what we also very often hear, especially from mothers, that they deal with guilt and shame. They think that maybe the epilepsy is caused by circumstances early in the pregnancy or during labor. And a newly arisen DNA variant in the child has nothing to do with the behavior or the circumstances during pregnancy or during labor. Of course, that is just, to put it crucial, bad luck.
You know, I'm sorry for the interruption, but I think this is maybe the most important part of the talk.
Yes.
Because
Yes.
I think I think it's necessary that the family members just to be very clear about this situation, because this is the main concern for them, you know. And actually, this is the primary consultation during my talks with them. So I think it's a very important point.
Okay. Yeah, you might also, because this is one of my last slides, so we may also discuss this, or maybe there are questions about this, or I don't know how you would like to proceed from now on.
No, I think that you just continue with the presentation. I just want to point it because this is very important.
Yes, okay. Well, we may come back to that later, but it's indeed also, in my experience, very important and quite a relief. Also, a genetic diagnosis often is also something to, it might also be bad news, but this is one aspect that may be reassuring, especially for mothers.
Yep.
Well, these are just some examples of consequences in treatment, and I will not go into much detail. But one development that is really taking place at this time is that genetic therapies are being developed. So these are therapies that try to repair the genetic defect, or that target the immediate consequences of that genetic defect. And at this time already clinical trials in patients are taking place. And we expect that, for example, for Dravet syndrome, within 2 to 3 years, a genetic therapy may become available. But the big problem, of course, is that these treatments will be very expensive. So we have to wait and see how effective it is, and to pay a lot of attention that all patients have access to this kind of therapies. And maybe very shortly about the reproductive options. I realized that this is the situation in the Netherlands, and I'm not sure whether in Curacao people can make choices like these. No. On the right, you see a picture which shows a chorion villus biopsy. So when there is an increased risk of 25% or bigger than that a child will be affected by a very severe epilepsy syndrome, a monogenic severe epilepsy syndrome. Parents may have a chorion villus biopsy performed, and in the chorion, that is the placenta, is that also the Dutch word? Yes, the moederkoek. The DNA is the same as in the child. So in the DNA laboratory, the test is performed, and the results are now within 2 weeks. And then the pregnancy is in the 13th, at the end of the first trimester. And if the child appears to be affected, parents may decide to terminate the pregnancy, which is, of course, a very difficult decision to make. And an alternative you see on the left, that is the fertilization occurs outside the body of the mother.
Dr. Eva, we are not hearing you. It froze up. Bruna, you think you can call Dr. Eva? Your
Yeah, it's frozen.
Yeah. Bruna, can you call Dr. Eva to tell her that Perhaps she already knows. Your oh, you have
Just done.
your mic silenced. Bruna, you have your mic silenced.
Yeah, sorry. No, she's, I think it's the internet. Let me see. Because she's out.
I'm very happy that in the Netherlands they also have problems with the internet. I was feeling. No, I mean we have flow here. Hello.
Good
Or maybe,
one.
You know,
maybe Dr. Daza, you can elaborate a little about something, Curacao, about genetics and epilepsy. I will try to contact, in the meantime, Dr. Brilstra.
Well, for us, it's not as easy maybe as then, because we don't have those genetic tests here.
Mhm.
Most of the time, we have two meetings during the year with the genetics from the Netherlands. So during this meeting, we have these clinical case presentations in which we can choose one of them can go for genetic test. But previously, we need to have a really deep conversation regarding not only the clinical setting, because most of the time we also have to keep in mind the cost,
correct.
okay, behind this and
The
the
cost
time.
effectiveness really, because what would we gain from the
Exactly.
genetic testing?
Exactly, because most of the time you can be realistic with the diagnosis. I mean, for example, with the Dravet syndrome, most of the time you can maybe has the suspicious that the patient has the syndrome, and this is epileptic encephalopathy. And most of the time, you know about the clinical course of this disease. So it's not too necessary just to double check if there is or not a genetic test positive or negative, in this condition. Because actually, what are the anti-seizure medication that maybe it's not a good idea to start with it.
Mhm.
So yeah, this is the maybe the gap that we have here in the
Mhm.
hospital because of the cost of this test. And
But
actually, because you most of the time know what is the relation, the genetic relation in this disease. But yeah, I think it's necessary, and I think that the community needs to know that most of the time, yes. I mean, the answer is yes, we can go for the genetic test, but most of the time it's not so necessary to go for that regarding the cost and the time, because
yeah.
sometimes it takes 4 or even 6 months to have the results. Okay, you're back.
Hi there.
Welcome again.
I'm so sorry. I just lost connection. But my presentation, it was really, yeah, thanks. Thanks. It was really
We
well.
were
So
just,
please
we
continue
were just
with the talk, with the discussion.
happy that these things also happen in the Netherlands. The connections that are.
Yes. Yes, yes. We can do pre-implantation genetic diagnosis, but take care of a proper internet connection is not so easy.
Yeah, yeah.
No, I'm sorry. Sorry for that.
Okay.
Do
Would
you
you
want to
like?
go with your presentation?
No, that was the last slide, so I actually
Oh,
finished.
okay.
So
Really?
I'm
Because
happy to take any questions or yes.
Um, we were just talking, waiting for you to get on back online. Dr. Eva, we were talking about what or Dr. Anilu was explaining to us what would be happening in Curacao, and it's really a very important important to keep in mind the balance about the balance of costs to the whole community, because unlike the United States, we do have universal healthcare. Um, and what will we gain by genetic testing? Um, I did gather from both of you that in the case of the Dravet syndrome, do I say it correct? Dravet syndrome, it does have a place in the clinical management and future of the patient with Dravet syndrome. Um, but what else can we expect of what would be the effects and the cost effectiveness of genetic testing in other patients with epilepsy, in the sense of when would we do it? Would it be interesting at the beginning when they're children or young adults, or would this person be earmarked to get genetic counseling when they are adults and perhaps going to have children themselves? It's wonderful to have these breakthroughs, but we do have to translate them into, okay, so what are we going to do next with these things? We are not hearing you, Bruna. Bruna,
You're mute.
you're muted. Bruna.
Yes.
Yeah.
No. Now, before going to answer the question Yaskara I have another question too in the same direction. Somebody asked, "Good morning. So, if I understand correctly, the genetic testing is not available here in Curacao. So, maybe you can combine the answer for the one asking with what Yaskara bring on the floor too."
Would this be a question for Dr. Daza? Yes.
Yes. Yes.
Yeah.
Okay, well, the answer for that question is we are not allowed to go for the test here. I mean, we don't have a geneticist here in the island, you know.
We don't
but
have
we can
a genetics lab here.
expertise, exactly. But we can take the sample, or most of the time during the year. When I was talking with you previously, we have 2 meetings, okay, with some geneticists from the Netherlands, in which we can discuss these cases, in which we can offer maybe a genetic test, you know. So we go for the clinical discussion, and after that, we choose those patients. And at that moment, we can offer how to take the sample. Most of the time, we can take the sample here and send the sample to the Netherlands. Or sometimes the patient and the family can go to the Netherlands and take the sample there. Okay? So that's most of the time the way that we can approach this type of patients. But previously, we need to discuss about the necessity and what are we going to gain with the test. Okay, if it's going to change the therapy, it's going to change the way, in the sense, if we are going to discuss with the family and talk about the prognosis, okay, or even about the counseling. Okay, because most of the time the question for the family is, okay, what's going to happen if I am going to have another children? You know, what is the risk of, what is the chance to have the same condition in my next children? Okay, so the answer is that it's not so easy for us, actually, and even again, most of the time we know what is the prognosis, and we can have like an answer for the patients and even for the family. But the answer is yes, in some cases, very specific cases, okay, in which we need the result of the genetic test just to have a more clear clinical condition, you know. And sometimes, yes, it's necessary because we can choose the best anti-seizure medication for those patients. That's, I think that this is the best answer that I can give you. Okay. I don't know, what is your thought, Dr. Eva?
Yeah, well, I think that in common epilepsies, it is often not necessary to do DNA testing. And there's some general knowledge that can be discussed with people with common epilepsies who want to have children, and you can reassure them. in most cases. But especially in young children who start having a developmental and epileptic encephalopathy, I think, it may contribute, and it may even be cost effective. But that also depends on the other investigations that you would perform in the child, as long as you don't have a genetic diagnosis, like MRI scanning or other investigations which may also be burdensome for the child. And then
even the EEG recording can give you a lot of light in these patients.
Yeah. So I think especially in this category, it would be good to have access to genetic testing. Yeah.
It's I can understand that it would be very like a bright hope on the horizon for parents with I say always parents, but I can imagine also the patient itself, to have, perhaps now we know the genetics, perhaps I can benefit from this. But it has to be clear that only a certain group of patients and persons will really clinically benefit from genetic testing.
Yes, that's true.
Because a lot of times they see we as a community see a new ontdekking, a new thing, as this is going to help me, and in most cases it does not. So, and this is especially with people that have difficulties with getting used to the medicine, and with with recurrence of their attacks, even with medicine, etc., with therapy. I can imagine that, okay, this is going to help me, but it has to be very clear that it's not really. In most cases, it will not. So
That's right. Yes, that's indeed an important thing to state. Yes.
yes.
Yeah.
On the other side, I think you both said it very well, that in some cases, it's if it could be done easily, which it can, it does alleviate the parents' sense of guilt, and this is my fault. I did this to my child, etc. So
I want to ask a question. How common are genetic causes of epilepsy among patients? How common is that?
Well, that depends on the subtype of epilepsy. So, especially in the epilepsy with the comorbidities, it is very common. In the majority of patients, we think that there is a monogenic cause, and we can find it in about half of them. But in the common epilepsies, it is only a small percentage of patients who have a monogenic cause.
Okay.
So just to be clear, and to be sure that I understood. So epilepsy, the genetic factor or the genetic impact is present in cases of epilepsy with some comorbidity, for sure, the developmental conditions. So if we see achterstand, how do you say achterstand in English? I don't know. If you see a child is not developing, etc., then you would, and it would have an
retardation, you can say. I think.
It would
Like
have
a cognitive delay.
okay.
Yeah.
Okay. But in normal epilepsy without a comorbidity, the impact of a gene is not large. One single gene or a group of gene is not large at all.
No.
Okay.
Can you
Most of the time, if you are working in a research team, for example, maybe it's necessary to go for the specific genetic test, but it's only for the research field. If you are
Yes.
working in an academic center, for example, and
Yes.
you have a research in something, for example, in the frontal lobe epilepsy, the nocturnal frontal lobe epilepsy, which is a very specified group of epilepsy, you can request the test, but not all the time. Okay.
What kind of epilepsy? Remember that I have no clue what epilepsy is, so I'm really happy that I can ask these questions. What kind of epilepsy you said? Frontal lobe?
For example,
That you
it's
said
just
nocturnal. That you said nocturnal also. No?
yeah, it's a nocturnal frontal
Okay.
lobe epilepsy. So there is a group of patients that can have seizures during the night, during the
Okay.
sleeping time.
Yes. Uh-huh.
So they are most of the time confused with the parasomnia or with abnormal movement during the sleeping time, because there are short brief of time in which the patient just wake up and maybe is doing abnormal movement, or sometimes is screaming, or sometimes is acting weird. And sometimes it's happened during the several moments during the sleeping time. So you can consider this working diagnosis that maybe could be maybe a sleep disorder, or just this type of epilepsy, that it could be frontal lobe epilepsy with nocturnal seizures, or even temporal lobe epilepsy with nocturnal seizures. So if you have this research, for example, or you have this suspicious, you can just go for also video EEG, which is a long recording video EEG in which a patient is admitted in a unit epilepsy center. So we can have the electroclinical correlation. It means that the patient is going for an electroencephalographic test, but at the same time, we have the video recording.
Okay.
So if the patient have this type of seizures or events during the night or during the recording, we can go for the electroclinical correlation and say, yes, this is the episode, and we have the EEG recording at the same time, and this is epileptic, okay? So we go for MRI of the brain, okay? We go for the neuropsychological test, psychiatric test, and if we are still having doubts that it could be this type of epilepsy, we can ask for the genetic test. And most of the time, it is very helpful. For example, I work in Argentina also in the Hospital El Cruce. So this is a research center, actually. So we can go and show to the world, for example, the percentage that we have of this type of seizure, of this type of epilepsy in our community. So this is helpful for the other people to recognize this type of epilepsy.
Okay. But what?
And also because this type of epilepsy has like a more response to some type of anti-seizure medication. In this case, sodium blocking channels, for example. Yeah, the carbamazepine is the first option in this type of seizure.
Okay. I have a question. Somebody sent. I think most part of the question has been answered by Dr. Daza already, but I still want to forward it. She is saying, understandable. Then my follow-up question: what other tests are available to find the right treatment medication for a patient that is not done via trial and error? She says, proef konijn, as the finding of the right treatment can weigh heavily on a patient going through the trail of various medication, not affected only the body itself, but also the patient mental health. Understandable? I don't know who want to answer that.
Maybe Dr. Eva want to go first?
Yes, well, I think there's very little room at this time for genetics in answering this question. So there's a limited number of monogenic epilepsies which at the time you diagnose it goes along with advice for a specific anti-seizure medication. But in the future, this might change by doing pharmacogenetics and also getting more insight into the polygenic risk and maybe specific profiles which may point to specific anti-seizure medications. But for now, genetics play a limited role in this aspect, are not very helpful, unfortunately. Yes.
So to summarize this, at this moment, it doesn't have an impact on the trial and error phase to pinpoint which therapy would be the correct one or the right one for a certain patient. But down the road, this might be changing.
For a smaller part of patients, it may guide treatment, a genetic diagnosis. So it's not only interface syndrome, there are also other examples.
Okay.
Yes.
Okay, I hope we answered the question. Otherwise, I ask her to if she is not satisfied, she can also again put a question so we can answer it. But I think it's obvious.
I just want to ask Dr. Eva in the Netherlands, how long does it take, to obtain the results of genetic testing there?
Well, the regular it regularly takes about 3 to 4 months to have a result. But for example, if an epilepsy patient has very frequent seizures and is admitted to the hospital, we can have a turnaround time of 10 days. So we have a rapid genetic testing.
Yes, that's what I was going to add. There must be like a screening test already. Okay.
Yes. For example, for small babies who are in a neonatal intensive care unit, we have this rapid testing procedures. Yes.
Can I ask how much does it cost?
That's why I looked at you.
No, because I know the prices or the values in my country, in the Latin America, I know it, but I don't know how much does it cost in the Netherlands, I never asked.
Well, it changes.
I would like to know both prices.
Exactly.
I can compare now. And yes.
We may go on and order genetic testing in Argentina. No, but in the Netherlands, I don't know exactly, but I think to have a large gene panel in a child, it would be about 1,700 euros. But if you also include the parents, it is 3 times 1,700 euros. So that's about 5. Yes.
Like
so
15, 16, 17.
17. So a trial analysis, including the parents, it would be about 5,000 euros. So yeah, expensive.
Okay, but that's the price for the complete exome?
Yes, the complete exome in child and both parents. And our DNA laboratory is organized in that way that they do it one time. So if you sequence complete DNA, you can do all types of analysis. You can analyze the whole exome or the whole genome even. That is now standard procedure. But you might also opt for only a smaller gene panel, or if other possibly genetic conditions turn out like a cardiovascular disease, which might be genetic. You can also use the same sequencing data.
I got it. Okay.
And so it's stored, and you can analyze it, year after year if you want to, whenever. Yes.
And the rapid, the rapid screening of you don't have you. Well, one question before this: would that be a price because your it's part of your investigation, or is this what the insurance pays for this test?
Yeah, the health insurance pays this for the test, but these costs include, of course, costs of personal and It is more is covered than just sequencing the DNA and
No,
analyzing.
I understand, but it's very
Yeah.
important for us to know what because I know that some prices will vary depending on if you have a budget as an investigator. It
Yes.
will be different than what is available for the general public.
You're right.
Yeah. Yeah, if you want to have an exome sequenced as part of a research project, so you don't need to have it analyzed by a laboratory specialist and an official report, but you use it for research purposes, it would be, I think, about 300 euros or even less. So then just the raw sequencing, obtaining the raw sequencing data.
Okay.
And it will get cheaper over time. That's for sure.
Yes, that's the good news. That's the good news. Okay. Dr. Daza, you have anything to ask about that? You're laughing.
No. No. I'm okay with the answer, and I'm okay with the conversation. And I think that the most important point for the patients and even for the family members were clarified with the discussions. No, I think that is a very good meeting. No.
Yes. I wish more of the colleagues, your colleagues, would have participated, known about this, and participated, because I can imagine all the clinicians in the different clinical settings of the 6 islands would have enjoyed this. So because now at the end of the presentation, this is more in your straatje, that we say in Dutch. It's more your cup of tea than the general public's cup of tea, because of what I said before. It stimulates hope that is not there yet, and I want to stress the yet, because just like Dr. Eva said, down the road we might have pharmacogenetics that will help match a better therapy to each patient.
Yeah, in the
But
future.
that is not the current situation yet. Okay. So Bruna is yet again silenced.
I think that she likes to be muted.
No, I'm hearing, observing, and looking for the.
I'm the one with the dogs, and I do apologize for the dogs.
Okay. I want to ask Dr. Brilstra and Dr. Daza too. What do you think mostly? What you just said, Yaskara, is more. You say, giving hope to the people, but more for the future. But now, what is the most misconception that people now have about genetics and epilepsy?
Well, maybe I can say something about that. I think that what we talked about, that the feelings of guilt and shame, and then when a genetic diagnosis is made, that may give much relief in that respect. But I think it is good to realize that also if you are not in the situation then that you can get this genetic diagnosis, that it is very likely that this genetic abnormality is present, and that this kind of in the children with developmental epileptic encephalopathy, if you have a young child with such a condition, that it is very likely to be genetic due to a newly arisen DNA variant, and in most cases it has nothing to do with circumstances during pregnancy or labor, even if you don't know that for sure because you have no access to a genetic test. So there to reassure the parents also in Curacao who don't have access to this kind of testing, even without a genetic diagnosis, you should know that this is the most likely situation with your child. So there's no reason for feelings of guilt or shame.
Okay, okay.
I think that the best two lines for that answer is the last two words that you already said. I mean, there is no, that the family are not, and I'm going to use this word, they are not allowed to feel guilty for this, you know, because sometimes it's bad luck. It is. So sometimes even we don't have any reason for that. And sometimes, yes, we have it. But most of the time, no. So I think that's the best answer is that.
It's like type 1 diabetes, or yeah, or
Yeah, kind of.
or the yeah. Okay.
I just want to ask about the counseling, you know, to the family. Who provides this counseling there? I mean, the neurologist, the genetist, or the pediatrician? Or you are working together most of the time?
Yeah, well, I think the pre-test counseling is often done by the neurologist, the child neurologist, or the pediatrician. But if a genetic cause has been identified, patients are referred to the clinical geneticist, usually also to discuss consequences for further family members, for example. Yes. Yeah.
Okay.
Would they have a special training for that, or it's just something that you go with the flow, or is there?
Well, in the Netherlands and also in many other European countries, clinical genetics is a medical specialty. So we have a 4-year training program, just like a pediatrician or just like a neurologist.
No. I gather that, but I mean, counseling. To me, the word counseling, I might be
No,
wrong
you
in
don't.
this.
No, you don't receive extra training for that.
Okay.
You learn how to say that words to the family with time and with experience.
Okay. Just like you have to say, okay, no, let's not talk about that.
I don't know, but
I'm not going to say anything. Okay.
I mean, I didn't take a
because
course to
because it's
how
not
to
that
say bad
I
news.
don't want to be negative towards your colleagues, but sometimes physicians really cannot talk to patients. So I can imagine it depends on which field you're in, because some fields will develop more empathy in the
Yeah,
professional, but
yeah.
in comparison to the surgeon, for instance.
Now, I think that every specialist with time, you know, learn how to say bad news and good news, you know. I think it's just the process to become a doctor, no? I mean, with
Yes,
time you
bad
gain
news
this
I gather,
skill.
but the how you tell people the options, the so no, I was just because the word counseling in me makes me think, okay, they learn how to what to put forward and how to guide the person in some direction that is more convenient for them, for the patient themselves. So okay. But I understand. I do believe that some of this your specialties will make you develop more empathy than other specialties,
Yeah, and skills, yeah.
because you are confronted more with
Yeah, or perhaps you choose that specialty because you
yes,
think
yes, true,
it's
true,
important to
yes,
show empathy. Yes.
okay,
Yeah, but you know, I think maybe it's important to say that most of the time we can offer to the family go for even psychologist support, you know.
mm-hmm.
And if, for example, in my case, if I have to have the family meeting and explain the situation, most of the time I go with them and try to stay with all the family members together. So that way the communication is more clear, and
Mm-hmm.
that way all the family can clarify the question regarding the situation. So I think it's the best way to do that.
Yes, that's good. Okay, because one question or one word will trigger another one to put forward their question or their yeah.
Exactly. Yeah.
Bruna, you're again on the
The floor is yours.
the your
Muted.
Tell me. Tell me. Yes.
I believe we have had the have you received more questions?
No, I didn't receive more question, but I have a question I have written down during the week. I think you already talked some things about it, but I just want to ask again to Dr. Brilstra. What recent breakthrough in epilepsy genetics are you most excited about?
Well, actually, the field of genetics is moving forward very fast. So about 25 years ago, we only knew maybe 30 genes, and that was all we could analyze gene by gene, and not large gene panels. And then we identified all those other, or not we, but others, people in the researchers in the field identified all those genes and new sequencing techniques, which makes it much easier to analyze the DNA extensively and more rapidly. And now the most exciting development, I think, is the genetic therapies, which are being developed. But there's also a lot of ethical aspects and inequality aspects to take into account when these kind of treatments are being introduced. But that it is even possible to send some molecules into a body by the blood to a target organ, and in the target organ repair the DNA. That I think that's amazing.
Okay, but that's more for the future, you can say.
Yes.
Yes. When the gene therapy will become a realistic treatment, in my opinion, for the epilepsy future.
Yeah. Yes, that's for the future.
That will be a great advance in that field. Dr. Daza has to leave in a couple of minutes, so we're almost at the time, but Dr. Daza has to leave earlier. So we thank you very much, Dr. Daza, for your time and your dedication into the panel today. Thank you very much. And what will I say? We hope in the future we can make use of your knowledge.
No, it's not enough. No, thanks to you, and thanks to Dr. Eva to be with us, and actually for your talk. It was, I think, very objective talk, because I think that most important things were discussed in this meeting, and I think that it's very important to the epilepsy patient and family of the patient with epilepsy to just take a look of this talk later, because maybe they are going to be more calm about the situation,
Yes,
So
yes, I think so too.
Yes.
And this session will be available on the Facebook. It will still be available on the Facebook. So afterwards, the people can still go back and hear everything we talk about it today. And still, if they have question afterwards, they can still send it up, and we will make sure that they will get the answer. So,
later.
Yes. That's
Sure.
We can do that. Yeah.
okay. So you're leaving us. Thank you.
Have a nice day. And again, thank you for
day.
Have a nice weekend, doctor.
Bye-bye.
Bye-bye.
Bye. Oh, yeah. Yes. Oh, I click very rapidly. So we're almost on time. Let me see if I didn't get any question more. I think maybe it's very much information for the people. So it have to sink down, can you say, and then afterwards they will come with the
I,
answer. Because
I have
yes.
a really it would have been a great question also when Dr. Daza was present, but perhaps Dr. Brilstra can tell us what is the prevalence of Dravet syndrome in the population, and what is the proportion of these cases in the totality of epilepsy patients.
Doctor, before you start, Yaskara use a word. I think for
Prevalence. It's
people maybe not in the medical field is not very clear. The
really,
prevalence, if
you
you
are
can,
going to
sorry?
Dr. Brilstra, her entire presentation.
I don't,
What I mean to say is, if we take 1,000 or 10,000 persons in a community, how many of them would have um, um, the Dravet syndrome? You know, how many people in a population would have Dravet syndrome, and how many
or
um,
any kind of epilepsy who has
that would be part of how many people in a population would have epilepsy. I yesterday with the data of the WHO, um, I calculated that you would have like a half per it one a little bit more than half a percentage of the world population has experiences epilepsy.
Yes, as I understand it,
Very low.
between a half and 1% of people have at any time of the world population have epilepsy if you look at it at a specific time. But if you look at the percentage of people who develop epilepsy at any moment during their life, who ever have epilepsy, it's about 3 to 4%, I think. And the prevalence of the birth prevalence, so the number of newborns who develop Dravet syndrome within the first year of life is about 1 in 20,000.
Oh,
So I think that would be about 1 in every 1,000 epilepsy patients, roughly, has Dravet syndrome. So it's a rare condition. It's really a
very
rare
rare.
condition.
Okay.
Yes.
That's what I was going to ask Dr. Daza, how many we would have in Curacao or in the Netherlands and Antilles.
Yeah. How many newborns are there in Curacao every year? Do you know?
We are down at 1,200, so we don't have that many birds. We are in the full vergrijzing.
Okay. So you only would have a new Dravet syndrome patient in every 15 or 20 years.
Yes.
So yes.
Okay.
yes.
Okay. Um, I don't have any more questions.
I don't have any question too. Well, let me ask. Dr. Daza said, and I know it early on that that was the case, that there is some specialists coming to Curacao, especially for handling with patients with genetic combination with epilepsy. Is that the case still? And are they from the UMC or from another university in Holland?
Yeah, I don't know if I know that one of my colleagues used to go, but I'm not sure if it was Curacao or one of the other islands. And it is not a colleague from the UMC Utrecht.
UMC. Oh, okay. I remember in 2019 we have a conference here, and we had as one of our guests there was one doctor, clinical doctor, specialized in genetics, and she gave also a brief introduction about epilepsy and genetic for us. I don't remember her name, but I think she was from the UMC.
Okay, maybe she was Mieke van Haalst. Does that sound familiar?
Yes, 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 yes,
yes,
yes,
yes.
yes.
She used to be in Utrecht, but now I think for more than 10 years she is in Amsterdam.
Ah, okay. Yes, Mieke van Haalst. Yeah, she did the session for us here in Curaçao. Okay.
Nice. Yes.
No, I don't have any question, and I didn't receive any question via the app. So, do you have something to say yourself, Doctor?
No, I think we've discussed a lot, and I enjoyed it very much.
Okay.
So thank you once more for the invitation, and I'm happy to answer further questions by email, for example.
Okay.
So please let me know if other questions, if people have other questions.
Okay. Thank you very, very much, Doctor. Let me ask first, Yaskara, do you have something to say or ask the doctor?
No, I enjoyed your presentation a lot. Most of it, I had no idea about it. It gives hope. What I'm most hopeful about is what you told us about both how rapidly things are rolling now in genetics, combined with your indication about the pharmacogenetics. So down the road, perhaps in 10 years, we can match therapies to individuals in
Yes.
better than before. But it's down the road. Is 10 years too much? Or you think with the AI it will be 3 years?
AI everywhere.
I don't know. I think it's very complicated. So I can't say, because pharmacogenetics is now not really something that adds a lot to epilepsy patient care. So I find it hard to predict how long it will take until we can immediately choose the best anti-seizure medication for an epilepsy patient without all those trial and error.
Really down the road. Okay.
I hope it's sooner than that, but we have to wait.
Yes,
Wait and see. Yes.
But thank you very much. That was very nice and to the point, and like Dr. Daza said, very objective. I enjoyed it a lot. Thank you.
I enjoyed it too, and I want to thank you very, very, very much, because you have a very busy agenda. But although you choose a Saturday, I think it's your free time to sit in your garden and enjoy the sun that is now shining in Holland. But you choose to take the time to help us with this information for all the people with epilepsy here in Curaçao, so they can understand the connection between genetics and epilepsy. Thank you very much, and we hope that in the future we can knock on your door if we need another help to answer question or to do another session like this. We can count on you. Thank you very much, Dr. Brilstra, and I hope you still can enjoy a little from the sun shining. Is the sun shining überhaupt?
Well, actually, no.
Oh, okay. We will send. We will send some for you.
You're sending some. I should have kept my garden as a background instead of the.
Make me jealous.
We will send some for you. We will send some for
Please
you.
do.
And maybe sometime we can welcome you here in Curaçao too, and to give a session about genetics, epilepsy. Who knows? We will work on it. Thank you very much. Have a nice day. And I thank everybody who follow us today via the Facebook van Stichting Epilepsie Curaçao Area Winkelaar. And thank you for following us. And if you have any question afterwards, send it to us and we will make sure that you get the answer. Okay, thank you and have a nice day.
Bye. Have a nice day.
Nice day.
Bye. Bye. Bye.